Dr. Dizon, thank you so much for coming onto the podcast. I'm so honored and thrilled to have you here. I know you're a very busy person, so I really appreciate your time. Thank you so much for coming onto the podcast.
I am a professor of medicine as well as professor of surgery at Brown University here in Providence, Rhode Island in the United States. My clinical focus is people with pelvic cancers, which are cancers of the uterus, cervix mostly, but I also treat people with breast cancer and soft tissue sarcoma. I have a special interest in the life after cancer arena, otherwise known as survivorship, as it specifically relates to sexuality. And I am a strong believer in the good that can come out of social media. So I am present in multiple platforms, including Twitter and TikTok.
So actually, in terms of the metastatic setting, do you think we have made as big a strides in terms of, in terms of research and the ability to kind of, treat them better and more efficiently and more effectively, I guess?
Well, I do think so. I think we have not induced long-term remissions in everyone who's been diagnosed with metastatic breast cancer, but the progress is, it comes in steps. And so a trial might show a 4 to 6 month advantage over what we do now. We become excited by that because again, for someone facing their mortality, if we can say we can get you 6 more months, if not longer, that's actually a great thing to be able to say to someone. I think it's really important that we not over-optimize the situation we are in. I just had this conversation with someone recently where I was asked directly, I just want to know I have 10 years or longer. And she had metastatic disease. And, I think the wrong thing for me to do is to say, I bet you will have 10 years, because I think it sets up someone with a goal that I am not at all confident is realistic. But what I can say is, I think you're looking at not dying. And I think you're looking at not dying anytime soon.
Yeah.
And so I'm still very careful, even with the options that we have. Unfortunately, treatments take their toll. And oftentimes what I'm seeing is people just get very tired of treatment. Sure. And even if I can always pull something off the shelf, sometimes it gets to a point where they're just not able to do it. And either they will say, I think I'm okay. I think I'm done. I'm done. Or it will be myself who has to say, I think it's time that we need to stop. So all the options in the world are great. But at the end of the day, people have to be able to undergo further therapy. And that, I think, is still something that is rate limiting for a lot of people.
Yeah, no, that is true. I mean, I think, we still need to continue to do research, both in the curative and the metastatic setting, right? And
yes. Yeah, I mean, I think a goal for people with metastatic disease is to live, I'm hoping, short of cure, that we can convert metastatic breast cancer into a chronic disease.
Yeah.
And, and I do see people living with metastatic disease just get very upset when it's called a chronic illness, because they see it as a death sentence. There's no chronicity if they're living their lives with a span in months. That's the context by which they live. So if we are truly able to get metastatic breast cancer under control to the point that people can see it as a chronic illness, I think that would be a gain.
Yeah, no, absolutely. And I think following on to what you've mentioned about, side effects, both from chemotherapy, but also, as you said, the anti-hormone tablet, so letrozole and tamoxifen usually. And many people, on endocrine treatment do suffer quite a lot. And, you know, as physicians, we just, okay, you know, this is what you should have. These are the reasons why. This is, you know, the percentage benefit.
Yeah.
Off you go. But a lot of people do suffer with these treatments. Are there ways? Firstly, what are the common side effects, I guess? But then secondly, what can they do to help mitigate those side effects, specifically really with endocrine treatment?
Yeah, I mean, I think you're right. You know, I think one of the biggest advances in the treatment of hormone-positive breast cancer has been availability of these anti-estrogen therapies or oral hormone treatments. You know, with tamoxifen, not everyone's favorite drug these days, but, you know, if you look at the big analysis on tamoxifen, it's still a very powerful drug. We worry about, you know, blood clots forming, hot flashes. You know, people are very concerned about weight gain on tamoxifen. That was not borne out in the randomized trials. That was not a toxicity experience in or reported in those trials.
Yeah.
And then we worry about the risk that they may develop endometrial cancer. And of course, once you mention cancer after treatment meant to stop cancer, that is something that people cannot get their heads around. The aromatase inhibitors only work if the ovaries are no longer functioning. And, you know, for younger women, this is where ovarian function suppression comes in. The use of medications to put the ovaries to sleep basically render someone immediately menopausal, so that they are eligible for the aromatase inhibitors. But aromatase inhibitors, as good drugs they are for cancer, are very hard to tolerate for many people. So there's joint and muscle aches on these drugs. And, you know, I do have patients who stop these treatments because the muscle aches became too problematic. Sexual side effects are significant with the aromatase inhibitors, and the experience of, you know, a rapid and sudden onset of menopause is not something that many young people are prepared for or are able to handle. So all of this in turn, I think you mentioned it already, that it has an impact on whether or not they're able to take the drugs. And, you know, the tolerance issues does have an impact on adherence to therapy.
Yeah.
And, you know, things that we can do, surprisingly, you know, maintaining a healthy lifestyle, maintaining activity, regular exercise, walking frequently. Those are actually things that can help with fatigue, but also can help stave off the muscle and joint pains on aromatase inhibitors. You know, for sexual side effects, you know, acting on that quickly if sexuality is something that is still present in one's life, or if this is something that people want in their lives, then, you know, aggressive management with vaginal moisturizers and the use of lubrications during sexual activities can be done and are important. And then for people who don't tolerate an aromatase inhibitor, say they're on anastrozole and having issues, what I find very interesting is that oftentimes you can stop the offensive drug and prescribe something else in its class and find that one is actually tolerated. So, you know, they are not all the same, is what I would say. And oftentimes someone will be able to tolerate B if they were not able to tolerate A.
Right.
So, I mean, I think part of it is just listening to people that are on these drugs, not blowing them off, but also providing them the information they need so that they're not shocked when some of these side effects occur.
Yeah, no, that's really helpful. Have you found that, you know, say an anastrozole made by a company versus another company have two different side effect profiles?
Yeah, I have not. And, you know, I'm a big believer in the use of generic drugs. I haven't seen any differences in the risk profiles. Now, with the CDK4/6 inhibitors, there are definite differences in the side effect profiles of those drugs. When you look across the class in the aromatase inhibitors, side effect profiles tend to be very similar, but the ability to tolerate the drugs is what's idiosyncratic, it seems.
Right. So what are your thoughts about HRT?
Yeah. Well,
Obviously in those who have had breast
yeah.
cancer.
So unfortunately, hormone replacement, which in the US is called hormone therapy, very simply, not to be confused with the
Right.
hormone therapies in breast cancer, which are really anti-hormone therapies.
Yeah.
But the use of estrogen after a breast cancer is really contraindicated based on 2 randomized trials. Neither of them were perfect. Neither of them answer any questions related to the preparation of the hormone therapies. But both, at least the U.S. trial called the HABITS trial, showing an increased risk of breast cancer events if you use hormone therapy. Now, I always come back to this issue that not all hormone therapies are created equally, though. And even in a now historic study called the Women's Health Initiative, the risk of breast cancer was associated with the use of combined hormone therapies, estrogen and progesterone. But when you looked at the cohort of women who had a hysterectomy and therefore did not need progesterone, the use of estrogen only hormone therapy was not associated with an increased risk of breast cancer.
Yeah.
Unfortunately, that is lost in the recommendations because our studies have never studied specifically what preparation to use for hormone therapy. So I think the bottom line is, particularly for people with hormone positive breast cancers, hormone replacement is not a great idea.
Mm-hmm.
Now, for women with other types of breast cancers, particularly hormone receptor negative, I think it's unclear. We do worry about crosstalk between hormone receptors, even in someone who has ER, estrogen receptor negative breast cancer. So crosstalk between estrogen and these ER quote negative cells, for example. I have prescribed hormone therapy in someone with triple negative breast cancer after they completed chemotherapy, but it really becomes a risk benefit profile that the patient needs to inform you about. In this case, she was having severe menopausal symptoms, and her sex life was exceptionally impacted, and she insisted on hormone therapy. And I was willing to give it to her because her disease was triple negative, and she understood the unknown consequences of this treatment in someone with triple negative breast cancer, because we just don't have good data at all.
Yeah, it is difficult, isn't it? Because patients can be really, really severely affected by it. And at the end of the day,
and it's like it's an interesting thing to talk quality of life when people are so scared of dying. But it's so important that we try to do both.
Yeah, because at the end of the day, quality of life is super important,
It is 100% important, yeah.
So you said that at the start you were interested, in kind of survivorship, and
yeah.
You talk about that and what kind of things you're involved in.
Yeah, here at Brown, I was fortunate enough to help start our wellness program. So we've entitled our wellness program the Oncology Wellness, Lifestyles, and Survivorship Program. And we did that on purpose because, for good or bad, survivorship has been embraced by people who are without evidence of their cancers or were treated with curative intent. And people living with metastatic breast cancer, not uncommonly, do not associate themselves with the term survivorship. But people with metastatic breast cancer are still interested in sexuality, and they're still interested in healthy lifestyles, and they're still interested in nutrition, even if they have an incurable illness. So the way we defined survivorship at Brown was to say you become a survivor from the point you are diagnosed, as well as the people who are supporting you are also survivors of your cancer. So this is very much in parallel with how the National Coalition for Cancer Survivorship, how it is defined for them.
Right.
And I think it's what we've sort of done with our program. And my contribution to that program is to provide sexuality services for both men and women treated for cancer. And I think, you know, even now it's an issue that very few people have the opportunity to address, but it is so critical for so many. And I think for any of your listeners who have ever heard a doctor tell them, when asked about what about my sex life, if a doctor tells you you should be thankful because at least you're alive,
Yeah.
never accept that as an answer.
That's a terrible answer. Nobody should be.
It's a horrible answer.
Nobody should be
is,
saying
100%,
that.
I agree.
Wow. So that's really interesting. I mean, that sounds such an amazing kind of, you know, initiative, really, because, you know,
we're proud of it. Yeah.
What kind of services do you provide, and you know, what kind of things can you offer, and what do you do?
Right. So what's interesting is that I hired one of my colleagues in primary care to be the director of it, and her name is Christine Duffy. But she has always had an interest in cancer survivorship. So she was very willing to become its clinical director. And what she was able to assemble, which is very unique, is that everyone who is seen in what's called the OWLS program is also presented to a multidisciplinary panel of non-oncologists.
Right.
So she has assembled pulmonary medicine, cardiology, neurology, GI medicine, nutrition, wellness, rehab, endocrinology, sexuality, nutrition, physical therapy, and we review patients who are being followed in the OWLS program.
Wow.
And the lovely thing about that is if one of us senses a need or senses that this person should be seen in our respective specialties, we can actually get them in,
right,
you know, and sort of bypass a quote wait list.
Right.
But having that sort of multidisciplinary environment to discuss people and what they're going through after their cancer, but not in front of other oncologists, but other specialists in medicine, has been really helpful to try to find people the resources they need to sort of find their new normal. So that's one thing we offer. We have a massage therapist and an acupuncturist that actually work in the center.
Wow.
We have a lifestyle coach who has been coming and providing that sort of directed guidance. And we have a rehabilitation physician who actually can do not only evaluations, but also plans for activity, which is really important because, as you know, people can sometimes become very debilitated from their treatment.
Yeah, that's such an amazing initiative. You know, that's just like the holy grail in my opinion, because you know, honestly,
it was. Well, I seriously think I credit Christine for assembling a group or finding people who are willing to get together and think through the issues that are important to people being seen in a post-diagnosis clinic.
Yeah. So do people then get funneled to you, or do they have to self-refer? How does it work?
So the referrals can come from anywhere. You know, it was slow for a little bit when we first started the program. Most of the referrals were coming from the breast program, for example. But now we're at the point, we've been in existence, I think, for 3 or 4 years. And there's a waiting list now for services. It's not a long one, unfortunately, but, you know, it can take up to 8 weeks before someone can get an initial consult. You know, we are always able to squeeze in people who, you know, I'm told by colleagues, you know, this person should be seen sooner for X, Y, or Z. We can always accommodate that. But it is a testament to how embraced it's been that there's a wait list to get seen.
Yeah, because, you know, I think the reason why I think it's so valuable is it's when patients finish treatment and then leave, you know, the hospital setting, that's when they need the most help. And, you know, we in the UK, we don't really have that facility to look after patients post-treatment when they need us the most, in essence, because, you know, they might feel slightly lost, there's no direction, you know, they're experiencing all of these problem side effects, you know, they would need direction.
And honestly, for us, there's someone with a new diagnosis also needs our help.
Yeah.
right?
Absolutely.
That's the unfortunate reality for those of us who actually, who do treat people with cancer. We don't have the luxury to be able to see them post therapy.
Yeah, there's no time, and we want to spend more time, but we can't. And not everybody will need necessarily help and direction, but for those who do, at least they know. Certainly at Brown, they know where to go, and they have that option.
Yeah. I mean, sometimes we refer to, people can self-refer, but social workers can refer their nurses from the infusion unit can refer. I mean, it's not by any stretch of imagination a program that is meant to be inaccessible. It's a highly accessible program.
Right. That has opened up our eyes, from my eyes really, as to what's possible.
Yeah. I mean, and so much of it just depends on finding those, for lack of a better, champions within your community. There are docs who are not oncologists and not surgeons who see these patients and see the need and want to learn more. And we were just able really to tap into that.
Yeah.
And it's been really, really nice.
No, that's fantastic. Well, this has been such a fascinating conversation. I'm so glad that we managed to sit and chat about all sorts.
Yes, I'm glad we finally got to do this. I am so sorry.
No, it's probably my fault. So yeah, Dr. Dizon and I tried to have this conversation. I don't know, about a month ago, I think, something like that.
I think it was a month ago. I think it was pre-ASCO,
and complete failure. So it didn't happen. So I'm super excited.
But I'm glad we were able to do it now.
Yeah, me too. Absolutely. Do you have any other things that you want to touch and just briefly talk about that you feel might be important for those who are listening?
Well, I think the only thing I will push is that I do have this new role in the American Cancer Society as the editor of the journal CA, and it's the title of the journal is CA, a cancer journal for clinicians. But I think for your audience to know, the articles are freely accessed anywhere.
Oh wow! Okay.
And part of my new charge for authors to the journal are to make their articles accessible to people who are not oncologists, because the people who read CA are primary care docs and a lot of nurses, administrators, and other people peripherally involved in oncology. And one of those groups that I want to make sure that who are able to access the comment are people living with this disease. So we publish a lot of reviews. There was just a really nice one on hormone receptor positive breast cancer that was senior authored by Hope Rugo at the University of California, San Francisco. But yeah, the journal is CA. And if people are interested in some content, not behind a paywall.
Fantastic.
This would be a nice place for your audience to learn about.
So you've just been newly appointed the editor?
Yeah.
Congratulations.
Thank you.
That's amazing.
I just took over in June.
Oh, fantastic. Well, huge congratulations.
Yeah. Thank you.
So if people want to get hold of CA, where would they go? And then also tell people who want to know and connect with you, where should they go and where would you like them to go?
Yeah, so if you just put into any browser CA, a cancer journal for clinicians, it will pull it up. It is also accessible through the American Cancer Society website. And I think there's a page for journals, and it will come up that way as well.
Okay.
But yes, follow me on social media if you're on it, on Twitter, TikTok, LinkedIn, Facebook, at Dr Dizon.
There you go. Yeah, please do, because Dr. Dizon's TikTok's amazing. And he's the most well-dressed oncologist ever.
I try to bring that human face, just like you're doing, Tasha, to what we do every single day.
No. So yeah, I will leave all of the links, including CA's link and Dr. Dizon's links and handles in the show notes, so people can go and check that out. But finally, I just want to say to you once again, thank you so much for your time. You're an amazingly busy man, so I absolutely appreciate you taking the time out of your busy schedule to share your wisdom and knowledge to those who are listening out there. So yeah, I'm very grateful for your time.
Thank you so much. It was lovely to chat with you. Hopefully we'll be able to do this in person.
Yeah, that would be awesome, right? Yeah, definitely we'll try to do that. Thank you so much.
Yeah, that would be great.
Take care.
Take care.
Bye.
Thank you. Have a good weekend.
Yeah,
Tasha.
you too. Thank you.